Good morning, ladies and gentlemen. We go on with this echo salsa. And as you have already been introduced to Dr. S. Venkatesan, I will not stand between you and him. And he is going to talk about why the celebrity status for TAPSE in RV function, a critical analysis and evidence for that. Dr. Venkatesan,
Thank you, sir.
The floor is yours.
Yeah. Thank you, sir. Thank you for the opportunity to talk in front of stalwarts of echocardiography. I don't know exactly what's the meaning of salsa in academic sense. Anyway, it's an unusual topic to discuss a particular parameter of an RV function in a separate topic. As we know, the heart was imaged way back 4 or 5 centuries ago by Da Vinci. Later on, Harvey confirmed the circulation system, the right and left heart. And he published in a rare publication we know, Dimotu Cardis. The right ventricle, as we say, it is described in various things: forgotten chamber, neglected chamber. Those days were the ignorance, probably. Then, of course, recently Fontan said it's a dispensable chamber, of course, entirely in a different context, in a hemodynamic perspective. Of course, if you look at the pressure curves, the superiority of the LV is reflected in this curve. It's tall and standing tall, and the RV pressure volume loops just lies low down. Of course, RV handles the same stroke volume as LV. LV is preload, RV is afterload. Without RV, what will LV do? We know the RV function is always critical in certain situations, acute RV dysfunction, and congenital heart disease, especially in Eisenmenger syndrome, LTGV. Post-transplantation, RV function is always critical. And of course, we realize the most forms of DCM, RV function again is very much critical. So if you see this patient ejection fraction around 15%, you will be surprised to know this outcome is determined primarily by the associated RV dysfunction rather than the LV dysfunction. This was described way back in the circulation articles where the patients who have associated RV dysfunction decline very rapidly and the death ensues very fast. Of course, we know PPH also, the RV is the life-determining thing, not the LV. So it's ignoring the RV function is actually our ignorance, if at all, if we do that. Meanwhile, something happened around year 2000. While we are differentiating RV from LV in various aspects clinically, one man from Spain, I think you all know about him, Torrent Gossip, he suggested both ventricles are in a continuum and there is no point in differentiating RV from LV. The muscle fibers are encircled with each other with a septum in between. And he unfolded the heart into a single sheet. After all, it's nothing new because heart develops from a single heart tube as a looping in the early embryo stages. We realize much later it has the origin from the same structure. Of course, this is confirmed with the recent technological magnetic tensor imaging also. The fibers are very much shared between the two ventricles. Even though these two are continuum, in clinical cardiology, we need to assess and separate chambers, right from left ventricle. Of course, right ventricular function can be assessed left side also. We know the parasternal lift is there. The ECG, X-ray, echo, nuclear imaging, and MRI. MRI is considered as a gold standard, but it's not to be used in a routine fashion day to day. So we go back to the RV function assessment by echocardiography. Of course, we have a big guideline specifically dedicated for RV function analysis. One of the creators of the guidelines is sitting in front of us, Dr. Chandrasekhar. You can all discuss with him later. And the routine functional diseases, so many we have been discussed last over 2 days. The dimension, the size, shape, everything is important. The fractional area change. I'm not going to discuss these things. Real-time 3D derived volumetric analysis, the RV, ejection fraction, the strain imaging, various regional and possibly global also in the RV. These are the set of normal things of RV function indices. So many parameters are there in RV. One would get confused. So is there a simple and acceptable modality? Do you have one really? And we think it is there already, and we use it so often And in fact, we did a small survey among students and technicians, consultant, and the support for TAPSE was overwhelming. That is one of the reasons this topic was discussed. And if they ask why you chose this TAPSE, the responses were very interesting: simple, rapidly done, no edge detection, ECG gating not required, accurate parameter, and surprisingly, at least few of them tell this sounds good. So TAPSE, we know, is a tricuspid annular plane systolic excursion. There are two things, the plane and excursion is going to be important when we discuss. In fact, it's a plane, but when we assess in M mode, we are not assessing the plane, it's actually a point we are analyzing. This is very important when we discuss the limitations of this thing. And why we call it excursion, I'm not able to comprehend that, because it's not a motion, it's not a contraction. We use it as excursion. That means something more influences this movement. What we talk about this excursion is, this fibrous skeleton of the heart forms both the annulus. We concentrate on the right trigone, from that and the tricuspid annulus. This is the movement we think it reflects the right ventricular function. The one that moves horizontally, transversely, that is the one movement. This is from a software analysis of right ventricular function. So this is the movement we want to assess the RV function, which we think is exclusive property of the RV, which reflects the global function. We'll analyze that. How to analyze this one? Very simple thing. We have M mode analysis of this movement. This TAPSE is, I think you should be aware, it's not at all a new parameter, reported in 1984. And actually, I would say it's a resurgence of M mode echo, at least in this part of the thing. There is an Indian connection to this. Sanjay Kaul and Praveen Shah from Los Angeles UCLA University, they first reported this almost 40 years ago. How to measure TAPSE? I think every one of you will be very familiar with this thing. And it is the M mode cursor in a 2D, well-documented 2D image put across the lateral RV free wall into the insertion of the tricuspid leaflet. It gives a movement which is quite obvious, and we have to measure the vertical distance. You can measure the slope also, but the slope is, nowadays, it's converted directly into the vertical measurement by the software. It's a distance measured, minimum to maximum action at this point. So one more important thing is what part of cardiac cycle. We ignore the cardiac cycle as we can take from maximum movement. So, but in fact, cardiac cycle is important, end diastole to the peak systole. How to mark the end diastole is easier because R wave can be correlated with that. The peak systole or the end systole it's a little difficult to pinpoint the point. This is important because errors can happen if you make a mistake in measuring the peak systolic point. There are some fine-tuning measurements. You have to make an RV-focused apical four-chamber view. When angle should be absolutely minimum. As you know, if you cross-cut it, the TAPSE is going to become erratic. And timing on ECG is stored. Adjust the gain, sweep speed, slope to height, I think is automated. Don't rush, wait for the steady state for this annular movement. How to improve the TAPSE, avoiding measurements error. There is an M mode, color M mode, you can use it. The red, this point, the red and blue changeover point can be taken as a maximum excursion point. This will minimize the errors for the TAPSE measurement. It has been suggested, in fact, long back actually. And of course, there is a TAPSE, even though we say it's a M mode movement, it can be measured 2D also. In fact, 2D gives a direct idea of this TAPSE. Somehow, I don't know why this is not much popular. Probably it takes a little more time to do that. Coming to the normal levels of TAPSE, I know the ASE has given us a less than 17 millimeter at its cutoff point is probably 16. The one thing is correlation is more with the dysfunctional ventricle rather than the other ranges of the other normal hearts. This I told, slight angle tilt 4 to 6 I just recorded with the slight angle tilt can cause a 4 to 6 millimeter variation that can be quite substantial. And as you know, if a patient is a dyspneic patient, a respiration can swing the TAPSE. It's called translational movement. The point I told was its excursion is because probably, Professor Chandrasekhar will clarify that. Excursion, the word used is because the tricuspid annular motion is not dependent only on the muscular contraction. The translational movement can also affect it. there is a normality issue still there. There is no mild, moderate, severe normality. I think we need to define that also. How to countercheck TAPSE whenever you have a problem? And TAPSE and tissue S velocity always go hand in hand. So whenever possible, and of course, I should say always, you have to check the S velocity and corroborate with this thing. If the cutoff point for S dash is 9.5 centimeters per second. So this is a case of LV dysfunction showing TAPSE and S velocity going together. Coming back, why TAPSE is such a popular RV index? It is simple, reproducible, can be done in any machine. Probably that is the reason. Einstein said everything should be made as simple as possible, but not simpler. Maybe quite he's right. Steve Jobs said simplicity is the ultimate sophistication. Yes, we all tend to agree with that. But is simplicity alone is enough? Shouldn't be sensible and smart in anything in life? We'll see the confounders in some conceptual issues, available evidence, and errors in the specific situation. I already alluded to this. Heart rate and loading conditions, angle dependence are important points confound is in TAPSE. Conceptual issue, it goes with the anatomy of the RV and the physiology of the RV. We are not yet clear how much of each component of the right ventricle contributes to the systolic function. Some books, when I search the literature, it says varies between 50 to 70, radial free wall force is there, septal force is there, RVOT contracts independently. LV free wall, this is the latest concept, contributes 30% to the RV function. If you look at this RV free wall here, there is a transverse motion, even though we think a longitudinal function is the major thing, RV transverse function is also important. And right from the Rushmer's days in the early 1950s, the RV is actually a peculiar organ where it's called a bellowing action, where as it contracts, it squeezes. Some people call it a peristaltic movement or a sequential RV contraction like an intestine like. So, TAPSE is a global, regional, or it is regional. Without doubt, it's a regional. And of course, it's longitudinal. As I told already, it's a single point cut of the annulus. Annulus is a multiplanar structure, timing of exertion, which I already told you. So this is how the annulus looks. Imagine you are cutting a single point in the lateral aspect and saying the annular motion you are measuring. How problematic it can be, just think about it. So we should improve the TAPSE annular motion in a better way by probably 3D and other methodologies. Of course, studies are done with the various points in the tricuspid annulus showing considerable variation in the movement of the tricuspid annulus. This one is intriguing, the emerging concept. The right ventricular systolic function is not the sole determinant of tricuspid annular motion. This actually shatters the myth of whether you are assessing RV function at all. See, this is the fibrous skeleton over which the heart muscles is sewn around. And as you know, the RV muscle and LV muscles are sharing how intricate these interconnection between these two ventricles. So we have a problem, of course. We still believe TAPSE represents the RV function. But whenever there is LV dysfunction, the RV tries to compensate here. This is a case of a LV diastolic dysfunction. The RV is hypercontractile here to overcome the increased LV EDP. So the RV comes to assistance of the LV by the interventricular interdependence. This study always said here, the TAPSE is a normal one. LV dysfunction also pulls down the TAPSE. RV dysfunction pulls down little more. When both dysfunctions are there, the TAPSE becomes almost flat. So the LV contribution to TAPSE is very clearly proven. Now let us see how good is TAPSE for RV function. What is the evidence base? We have comparison of TAPSE with the aortic angiogram, FAC, 3D data, and MRI. The most of the studies are a correlation with the fractional area change with the TAPSE. This is the data based on which we have given importance to the TAPSE. Very good correlation, but I'm not clear whether FAC is still very much validated. There are meta-analyses comparing FAC with the TAPSE from Mayo Clinic. Arizona, and consistently proven this FAC and TAPSE are correlating. The one thing I was curious was, TAPSE is compared to the FAC, but TAPSE is very rarely compared to the MRI directly. But FAC is compared to the, so A is equal to B, C is not, cannot be always true. One MRI comparison studies clearly shows there is no correlation, much correlation with the TAPSE. So we have to probably go in depth into these things. But one thing is very certain, in spite of these uncertainties, when the TAPSE is low, the prognosis is bad, especially in a biventricular dysfunction. A large study from UK with 1,500 patients specifically looked in TAPSE in a failure, and prognosis in cardiac failure, which clearly showed in both heart failure, preserved LV function, and heart failure, the global LV dysfunction. Whenever there is TAPSE is low, the outcome is very much poor. So again, coming back to the thing, can it be trusted always? Unfortunately, the answer has to be no or right now. At least I don't know exactly sensitivity and specificity of this particular index. We are seeing normal TAPSE with preserved RV function, depressed TAPSE with the normal RV function are well known. Pseudo-normal TAPSE, I'll give you examples for this: tricuspid regurgitation, acute pulmonary embolism, or infarction. And pseudo-abnormal is a post-operative stage. One thing, tricuspid, whenever there is a TR, there is a volume overload of right atrium, and it seems to augment the motion of tricuspid annulus, especially if there's a tachycardia. This is totally confounds the issue. Yes, I'll finish off in 2 minutes. So the TR velocity is confounding that. This study shows the effect of TAPSE on the annular velocity when there is TR. TAPSE after cardiac surgery is again a well-recognized issue. Whenever there is a post-operative state, the RV TAPSE movement becomes very sluggish. And this has been proved with the studies. While FAC is maintained and TAPSE is low, clearly proven there is a dichotomy between FAC and TAPSE. Why the TAPSE should fall after surgery? It's due to the open pericardiotomy, altered geometry, or probably the RV adherence to the adjacent tissues. Pulmonary embolism, again, we rely on RV dysfunction to take important management decisions, but the problem is the pressure distribution in the various RV walls, it's not uniform. Please be reminded, so regional wall motion defects, McDonald sign, everything is based on that. And if you see here, this patient has an acute massive pulmonary embolism, thrombus in the RA, has got a very preserved TAPSE. It's a problem here. And even the S velocity is preserved. Still, the patient is in LV dysfunction. Some of the new observations we have made in our departments are, of course, this one is TAPSE is nothing but an X descent, coincides with X descent JVP. There are studies with TAPSE with the J pressures. That can be quite useful later on. And in cath lab, you are seeing the right AV groove motion, which actually reflects the TAPSE. We are trying to look at this, and during a primary PCA of an RCA infarct, once the RCA is opened up, see the motion of the right AV groove.
Dr. Venkatesan, we are overstepping
just
time.
1 minute, sir. This annular motion can be used as a TAPSE equivalent. And we had recently one case that after annuloplasty is done, this gives a direct view of the trigeminal motion. So concluding question is, TAPSE will remain popular parameter for some more time. Methodology is important. Understanding the concept behind motion is vital. It doesn't reflect the global RV function. Probably it's not reliable in important scenarios, but don't go with alone. Use S dash for counter check. Finally, TAPSE could reflect more of a biventricular function. And the clinical echocardiography has gone a remarkable journey. We are seeing in the last 3 days, the imaging is really breathtaking imagings are available. But still, this TAPSE reminds me, it's the old times, when Erdler and Hertz used this reflectoscope and first recorded the mode imaging, and we are going in a retro journey. Thank you for your attention. Thank you.
Please join us here on the dais, and we will have discussion at the end of. Should we have at the end? That would be fine. Please come and join us.